Hey guys, today we're going to be covering Chapter 24, Environmental Emergencies. In these chapters we'll go over heat and cold emergencies, how people are exposed to cold and heat, also how we treat these type of emergencies. We'll go over hyponatremia, bites and stings, lightning strikes, as well as high altitude sickness. Environmental emergencies is caused by some type of disruption by the body's physiological response to elements within our natural environment. These elements can include climate, lightning, altitude, and even contact with insects or animals. So the body, with the integumentary system in correlation with it, um, works to maintain a homeostasis temperature, which is 98.6. That is our normal body temperature. Now we have thermoreceptors within our body that monitors our body temperature. And these receptors then send information to our hypothalamus, which sends signals to adjust our body temperature. So if our thermoreceptors note that we're getting cold, the hypothalamus then signals to our body, which gives us goosebumps, causes us to shiver, and even causes a increase in our pulse to warm our body from the inside out. When we are in a hot environment and our body temperature begins to increase, is when you start getting chills, sweats, whatever the body can do to decrease the body temperature from the inside out as well. Now, heat is exchanged with the environment from inside out through a thermal gradient. So that way, in which warmer temperatures move toward cooler temperatures. So the body responds to this as well. If it's hotter outside the 98.6 degrees, our body is now cooler, so the heat is then exchanged into our body. When it's cold outside, our internal body heat is exchanged with the outside environment. So the body thus responds by causing some type of response into the body to either increase or decrease the amount of heat that is produced or lost from the body. Now the body has two primary systems in which it uses to regulate body temperature, one being behavioral regulation and the other being physiological regulation. Behavioral regulation takes input from the thermoreceptors and provides information to the brain regarding the patient's comfort level. The patient then makes a conscious effort to change the sensation and comfort level by taking some type of action. If it's too hot, the person might take off some clothing, spray cool water onto themselves, fan themselves, or perform some other behavior to attempt to cool themselves. However, if the patient is too cold, they might add clothing, stand next to some type of heat source, get out of the cold or windy environment, or move about to increase their muscular activity, thus producing more heat. In physiological regulation, that input from thermoreceptors still providing information to the brain, and the body responds with a physiological action to change the temperature disturbance without any conscious control by the patient. In a cold environment, the body constricts the peripheral vessels to preserve body heat and initiating shivering to involuntarily produce heat. In a hot environment, the body dilates the peripheral vessels to facilitate heat loss and initiating sweating to increase heat loss through evaporation. Now the body must maintain an optimum body temperature, so that way cellular function can continue normally. If at any time the body cannot compensate for the heat that is either gained or lost, the resulting cellular and organ damage can lead to an environmental emergency. Now the body relies on three body systems: the skin, the cardiovascular system, and the respiratory system to help maintain a normal temperature when the body becomes too warm. Within the cardiovascular system, it's that vasodilation thus increasing blood flow to the skin, thus causing an increase in sweating through the skin, plus an increase in respiration to blow off that heat. Okay? When heat loss exceeds heat gain, so I'm losing more heat than I am gaining heat, that's when you become hypothermic. When heat gained exceeds the amount of heat that is lost, that is when you become hyperthermic. When the heat lost exceeds the heat gained, we want to try to take any action that we can to reduce a patient's heat loss. And we'll go over some ways in which it'll go over it, such as convection, on the next slide. Some other ways that we can do as providers is if we come up to a patient who is hypothermic or when they have lost more heat than they're able to gain heat, try to get them inside the back of our ambulance and turn the heater on. Now, heat loss occurs through 5 different mechanisms: radiation, convection, conduction, evaporation, and respiration. Okay? Now, radiation, this is a natural thing. This is when body heat is lost to the atmosphere or nearby objects without physically touching them. This is our normal body heat radiating. Convection is when heat is lost because of surrounding air. So that cold air is blowing past you. It is pulling heat off of you. You also lose heat through respiration. When you perspire and you are sweating, this can cause a loss in body heat as the liquid is evaporating. And if you are sitting on anything that is cooler than your core body temperature, it will conduct and draw heat from your body into that nearby object. Now, the process in which a liquid changes to a vapor is called evaporation. And evaporation does have a cooling effect. When body heat causes the body to perspire and the perspiration evaporates, the heat that has been absorbed by the sweat is dissipated into the air, and thus the body surface is then cooled. Now, if you have a high relative humidity, which we sometimes have in our area, this causes it to where when you start sweating, because there's so much moisture in the ambient air around us, that we do not sweat. So these patients are now more likely to suffer from a hyperthermic emergency because now they're not able to lose heat. Or they're not able to cool themselves off, excuse me. Now, when the amount of heat gained exceeds heat loss, or a hyperthermic emergency, is when the body is no longer able to cool themselves, such as that high humidity area, or when the air temperature is high. So in our area, or even in some of the other southern areas where the heat index might be 100, 110 plus degrees. Also, when there's no breeze in the ambient air, that also affects us because now we're not able to cool off through convection. Now, hypothermia, the body is no longer able to regulate itself as far as its temperature when the core body temperature has gone below 95 degrees Fahrenheit. A patient will become comatose when they have reached 79 degrees Fahrenheit, and the death rate in a hypothermic emergency can be as high as 87%. Now, you can have a sudden hypothermic emergency, such as when falling through into a lake or body of water that is frozen. Or it can be a gradual onset that is caused by exposure to cold air, cool water, or even wind. Now, as the body begins to cool, there are several effects that you will see. When the body's at 95 to 98 degrees Fahrenheit, they'll still be alert, They'll have cool, pale skin. Their heart rate and breathing will be elevated. They'll be shivering and thus have poor muscle coordination. Once we drop below 95, between 90 and 95 degrees Fahrenheit, or 32 to 35 degrees Celsius, our skin starts to kind of get a waxy appearance. Your face gets puffy, possibly even pink, due to the amount of vasoconstriction occurring, or excuse me, vasodilation. You stop shivering and your muscles become very rigid, and your heart rate begins to slow, and you become more confused. When you reach 86 to 90 degrees Fahrenheit, your pupils are dilated. You start going into a stupor, possibly even a coma. Now your heart rate is still slow, and now your breathing rate is starting to become slow also and become hypotensive because now the body's no longer able to compensate. Once we get down to 82 to 86 degrees Fahrenheit, now our pupils are fixed and dilated. We're comatose. Our respirations is even slower. You still have that slow heart rate, or even a rapid heart rate as the body's trying one last stand. And it is possible at this point to go into cardiac arrest. Now, once we get below 82 degrees Fahrenheit as a core body temperature, our vital signs are barely detectable. We have some severe cardiac dysrhythmias. If the patient was still responsive, they are now unresponsive. Cyanosis has now set in, and cardiac arrest is inevitable. And that is why with hypothermic emergencies, we want to we work them until we warm the core body temperature back up to this point, because there is still a chance of the patient surviving. Because as they become colder, their metabolic rate slows down, their neurological needs slow down, and there is still a chance of saving this patient. Now, there are some factors that could predispose someone to a hypothermic emergency. Because extremely low temperatures are not necessary for this to occur. It can occur in temperatures as high as 65 degrees Fahrenheit, depending on what the wind chill factor is. People who are at the extremes of age, such as infants and toddlers, and the elderly, are also at an increased risk of hypothermia. Newborns and infants, they don't have the ability to thermoregulate yet. And those that are at the elderly age, their skin is so frail that, and because of various comorbid conditions, that their body may not be able to handle those extreme temperatures, and thus they won't be able to cool themselves or warm themselves back up. Recent surgery, head injury, burns are also at an increased risk for hypothermia. Alcohol and drugs and also some various poisons can increase the likelihood for hypothermia because it inhibits the body's response. The amount of time that they are in the cold, if they are unprotected. Clothing, if you're in a cold environment, you want to make sure that you have layers of clothing. As well as physical activity that requires muscular movement that produces heat as a byproduct. Thus, a person who continues to move can generate internal heat that maintains the body's core body temperature at a higher level than if they were not moving. That's why it's important if you're in a cold environment to keep moving, don't sit still. Now, both of these groups are subject to hypothermia. This one who is dressed too lightly for the environment is not able to keep body heat in. This gentleman who's sleeping outdoors on this cool surface, not only is he losing heat through conduction, but also through radiation and convection. And then since he's apparently had alcohol on board, now the body's response to it is hindered as well. Table 24-1 goes over the various stages of hypothermia, mild, moderate, severe, and profound, and the core body temperature range that you would see in it as well. Now, hypothermia can occur with little warning and can progress rapidly from mild to moderate to severe and profound hypothermia. As the person's core body temperature drops, the body's thermoregulating mechanism and perception becomes confused. A person, even though dangerously cold, might undress because he or she feels that they are too warm. During those initial phases, they will their metabolic rate increases, they begin shivering, and they have piloerection or goosebumps. Now, in hypothermia, when these mechanisms are not enough to maintain body temperature. That's why it's important to have some type of heat source, whether it's a heater, fire, or clothing on to help maintain body heat. Now, when a patient is immersed in water, they are prone to having immersion hypothermia. In water temperatures less than 77 degrees Fahrenheit, an immersed person who is not wearing protective gear cannot generate enough heat from movement to maintain a normal body core temperature. In water temperatures that are below 68 degrees Fahrenheit, the person is at increased risk of dying from either drowning or severe hypothermia. These patients tend to lose heat 25 to 30 times faster when immersed in water than they will in the air. These patients go through two phases when they are exposed to cold water, either the cold shock response and cold incapacitation. During the cold shock response, this is the first phase of response to cold water immersion. The immersed person exhibits a respiratory pattern change with a hyperventilation and a gasp response at the beginning. They also lose the ability to hold their breath if they are not acclimatized to the water. Cold incapacitation is when the immersed person survives the initial cold shock response. They have approximately 10 minutes before they become unable to perform any useful activity. They lose fine motor function first, followed by a loss of gross motor function, followed by the inability to perform any useful or meaningful activity. These patients who are rescued need to be closely monitored because up to 20% of them could potentially die still, even following rescue after 24 hours. The reason for sudden death within 24 hours following rescue is related to, upon rewarming, the circulation of cold, acidotic, and even alkalotic blood back into the core circulation. Um, Also, because of the release of catecholamines, it can cause them to go into sudden death. Um, the baroreceptors that monitors blood pressure within the body, because they are cold, they're not as sensitive to blood pressure changes. So until they have a chance to warm back up and get back into function, they will take a while to be able to monitor blood pressure. Also, the heart could potentially have been affected also, so it is not able to pump as properly as well. Now, you can also have what's called urban hypothermia. Do not overlook the possibility of this in the elderly or pediatric patient who has been subject to the cool ambient temperatures of air-conditioned buildings. A patient in an air-conditioned environment who has decreased tissue insulation and inability to move from a cold surface is a prime candidate to suffer from urban hypothermia even on a warm day. Myxedema coma, this is a complication that occurs late in the progression of hypothyroidism and can be fatal. It occurs most commonly in elderly women who present with extreme hypothermia or core body temperatures between 75 to 9 degrees Fahrenheit, seizures, slow reflexes, and respiratory depression. Although myxedema coma occurs rarely, thus or about 1.1% of hypothyroid patients. This is a true emergency, and death from this complication is likely. You can also have some non-freezing cold injuries, such as immersion foot and trench foot. Trench foot, this was something commonly seen in military personnel. Results from exposure of the feet to a constant cold but not freezing temperature. Our troops during World War II, the one that were in the um, trenches, were suffering from this, and that's where it got its name from. Immersion foot, this results from prolonged immersion of the feet in cool or cold water or moisture. This can occur if the foot is kept in cool or cold wet socks for a long period of time. That's why it's important for when you're out hiking, working, whatever. If your socks get wet, it's important for you to change out to a pair of warm, dry socks. The key in your emergency management of non-freezing cold injury is to recognize this condition and to prevent any further cooling or trauma to the extremity. Do not allow the patient to walk or stand on the affected foot or feet. Remove their footwear and socks carefully, loosely cover the area with a dry, sterile dressing. And now freezing cold injuries, this is when you have a localized cold injury and what now ice crystals are starting to form between the cells of the skin. That where these areas are actually beginning to freeze. Um, these require much colder temperatures and that are needed to produce generalized hypothermia. So now we're in areas where it's below zero potentially. Just like with the hypothermic emergencies, freezing cold injuries do have some predisposing factors. Trauma, extremes of age, wet clothing, alcohol use, and even high altitudes can all predispose you to this type of injury. In these injuries, during the late or deep freezing cold injury, the skin will appear white and waxy, and they'll feel firm to where when you go to palpate them, and even feel like it's solidly frozen. There may be even swelling and blisters present also on it as well. If these tend pop, it will be these blisters are filled with clear or straw-colored fluid because of the plasma that is shifting from the vascular space. As it begins to thaw, the areas will become blotchy or mottled and colored from white to purple to even a grayish blue color. These are true extreme emergencies and could potentially result in permanent tissue loss if not treated early and aggressively. Early or superficial freezing cold injuries or frostbite. These patients are usually unaware of the injury, which commonly develops after direct contact with a cold object, cold air, or cold water. Um, these these injuries usually involve the tips of the ears, nose, and cheekbones. Late or deep freezing cold injuries, the skin is now white and waxy in appearance because now it's gone down to, it's the tissue beneath the skin is now getting frozen. Palpation of the affected area also reveals a firm to completely solid frozen feeling. The injury can involve the whole hand or foot, and this is when you will see those blisters with that the clear or straw-colored fluid. When assessing the scene, you want to make sure that the scene is safe. Okay, we don't want to go into any kind of situation where our safety is jeopardized, such as a frozen lake, for example. So look for clues to try to figure out how the environment has affected the patient. Or is there any mechanisms such as icy water, cold air? Is there any predisposing factors such as alcohol, trauma, or medications. Look at the patient's clothing. Is it wet? And are they dressed properly for the environment? What's the ambient temperature in the area? Is there any injury that could potentially interfere with thermoregulation of the patient? Once you've completed your scene size up, you want to then go into your primary assessment. Build your general impression. Are there any risk factors or indications? Assess their mental status. Go through your ABCs. Keep an eye out for carbon dioxide. Excuse me. Remember that carbon dioxide is a major stimulus to breathe in the normal patient. Thus, a decrease in carbon dioxide production decreases the drive to breathe, thus causing the respiratory rate and tidal volume to decrease and eventually become ineffective. So if they become slow, we need to start to ventilate. Check their pulse, because their pulse may be very weak. However, if you're not able to feel it, start chest compressions. Start going through your secondary assessment. Try to get them in a warm environment. If they are having a hypothermic emergencies, go quickly through your ABCs. Load your patient up on the stretcher, get him in the truck, turn on the heater. You even get some hot packs and place them in central areas such as the groin and in the armpits. Go through your history, try to find those predisposing factors. Go through your sample history. Go through your physical examination, looking for signs of trauma as well as hypothermia. If you're able to, get a baseline temperature, as well as get your baseline vitals. Be especially cautious for hypothermia when treating a patient who is resuscitated outside. Sometimes rescuers tend to lose track of the time as they work on a patient in a snowbank or on an icy road. So not only do we need to be worried about the patient, but ourselves as well. Look for those signs and symptoms of hypothermia, such as decreasing mental status, drowsiness, dizziness, joint and muscle stiffness, uncontrollable fits of shivering that eventually leads to little to no shivering, reduction in sensation or loss of sensation, changes in your vital signs such as respiratory status, pulse change, skin color, and slowly responding pupils, and eventually low to absent blood pressure. Table 24-2 goes over the stages of hypothermia as well as the physiological changes that you will see. I would recommend looking over this because you might be seeing these again later on, not only in this class but on National Registry as well. Continue going through your assessment. Care for these patients is, remove any wet clothing. If they are wet, try to dry them off. Cover them up to maintain their own body heat. Okay? Try to keep them warm as quickly and safely as possible. Now, if it's going to be a while before you have a chance to load the patient up and get them out of the cold-based environment, definitely if they have a frostbite type emergency, do not warm up those areas, because if you warm them back up and they're still in the cold environment, it could potentially refreeze again. Try to insulate the patient from the ground up. Get something underneath them as quickly as possible. Also remember to insulate the head, because that's where a majority of our heat is lost. Rough handling can also be careful when handling them, because rough handling can cause a cardiac dysrhythmia, especially ventricular fibrillation. Never allow the patient to walk or exert himself in any way. Even minor physical activity can disrupt the rhythm of the heart. Also, administer supplemental oxygen to maintain a sat of 94%. And if you're able to, use warm, humidified oxygen, because there's increasing evidence that the application of warm, humidified oxygen can be extremely beneficial to the hypothermic patient during resuscitation. If they do go into cardiac arrest, immediately initiate CPR. If VFib or ventricular tachycardia persists after the initial defibrillation, it might be reasonable to consider to defibrillate as the patient is rewarmed. Follow local protocols, continue CPR aggressively, because prolonged survival in cases of hypothermia has been reported. Some experts advise active rewarming only if you are more than 15 minutes from the receiving facility. According to AHA guidelines, active rewarming should be applied to patients with a body core temperature less than 34 degrees Celsius or 93.2 degrees Fahrenheit, or those suffering from moderate to severe hypothermia. Ultimately, follow local protocol and contact medical direction if unsure. Some ways to actively rewarm the patient. One way is to apply heat packs to the groin and armpits, as well as the chest. However, make sure you insulate the packs to prevent burns. And then cover the patient with blankets to maximize the effect of the heat packs. Passive rewarming is another method that you can take. This is taking measures to prevent further heat loss and giving the patient's body the optimum chance to rewarm itself. Now, this is only if the patient still has the ability to warm itself. This includes inhibiting further heat loss by wrapping the patient in blankets and increasing the heat in the patient compartment of the ambulance. Do not allow the patient to consume any stimulants such as tobacco, coffee, or alcohol, and never rub or massage the patient's arm or legs. You could force cold venous blood back into the heart, thus causing cardiac irritability or cardiac arrest. The safest rewarming takes place at a medical facility, so transport is the most important factor for these patients. So in this case, they have the patient fully wrapped up in blankets and have turned up the heat in the patient compartment. This is for passive rewarming. For emergent hypothermia, if the patient is still in the water, try to tell them to make the least amount of effort needed to stay afloat. The reason being is turbulence and activity in the water decreases survival time by approximately 75%. If the patient continues to move or struggle, they can cool more quickly because of the increase in the movement of cold water molecules next to the skin and around the body. Lift the patient from the water in a horizontal or supine position to prevent vascular collapse and provide spine motion restriction if spinal injury is suspected. Once you've removed the patient from the water, remove the patient's wet clothing carefully and gently. Excessive activity can cause the heart to go into ventricular fibrillation. If it is too difficult to remove the clothing, cut it off and layer dry, warm materials around the patient. Freezing cold injuries that are localized can be difficult to assess. While still frozen, even severely affected tissue can appear almost normal, with purplish or other abnormal colors appearing only with thawing. As the injuries are rewarming, they'll also have a tingly sensation as blood flows return to those areas. In the late to deep phases, the tissue can be completely numb when frozen but still be painful, such as burning, stinging, or throbbing, before it freezes and as it thaws. Although you might be unable to assess its severity accurately, you can almost always see a clear demarcation at the site of a local freezing cold injury. For these patients, never initiate thawing procedures if there is any danger of refreezing. Keeping the tissue frozen is less dangerous than submitting it to refreezing. Make sure you follow local protocol and try to remove the patient from that environment as soon as possible. For these patients, we want to try to maintain oxygenation. Try to maintain an O2 sat of greater than 94%. Prevent further injury to the injured area as well. Remove any jewelry, any wet clothing. If it is frozen or if you cannot remove the clothing or the jewelry, leave it in place. Also, secure the affected extremity to a board splint to minimize movement and elevate. No part of the injured extremity should be in contact with a hard surface. Cover the affected skin with dressings or dry clothing to prevent friction or pressure. And do not rub or massage the affected skin. If they have a if they have a late or deep injury, once again, remove any clothing if possible. Cover the area, don't rub it. Don't let the patient walk. Try to keep avoid any pressure on the affected area. And do not rub or massage the affected area. Also, if they do have any blisters, do not break them or treat them with any salve or ointment. Now, there may be times where we may have to do the rewarming, definitely if we have long or delayed transport. Only if there's not a chance of it refreezing. Rapid rewarming is preferred, however, it is going to be painful for the patient. To do this, we want to immerse the affected area in warm water. Try to keep the water temperature constant at around 104 degrees Fahrenheit. Stir the water to ensure that heat is evenly distributed, and keep the tissue in the water until it is soft and color and sensation has returned. After thawing, dry the area and keep it and don't let it get recold, and transport the patient. When you go through reassess, make sure you reassess all cold emergency patients routinely, because there is a chance that they could deteriorate. Keep a close eye on them. If they become pulseless, begin CPR. And be sure to check vitals every 5 minutes. Alright guys, we're going to take a break here. When we come back, we will cover hyperthermia. So go get something to drink, use the restroom, stretch your legs, whatever you need to do. And we'll be back shortly.